that focal point. So whenever you are looking at an organ, you see that suppose I want to look at this ovary here. If my focus is here, it will give a good view of the uterus but not that good of the ovary. So I need to adjust my focal point so that the ovary gets visualized in a better way. Using zoom, when we have adjusted the depth and the focus, we can also use the zoom to increase the magnification of the organ of interest for better evaluation. Using cine loops. So sometimes in gynae, yes, it is useful when we are looking at the dynamic ultrasound evaluation, that is especially when we are suspecting endometriosis, when you want to see the sliding of the organs or whether they are adhered. So imaging in real time and cine loop is more useful in those cases. And Doppler evaluation must be included as part of every pelvic exam. Using color Doppler, using power Doppler as opposed to color Doppler is more beneficial because it can pick up very small vascular flows. And to make all these adjustments quicker and make your examination quicker, you can save all these with adequate depth, focus and all, and then save it as a preset, so that you can simply switch it on when you are starting an examination. And always measure all the organs, whatever the normal organs, the ovaries, uterus, ovaries, and also whenever we find any other masses or abnormal findings, we need to measure them to quantify our findings. And as I said, 3D is optional. So timing of a scan is also important to get the maximum out of our vaginal ultrasound examination. We all know follicular tracking, we do usually, the patients are referred at around 9 to 10 days when we expect the dominant follicle to grow. But it is best practice to start your follicular tracking with a baseline scan on day 2 or day 3, where we have an idea of the ovarian reserve and also we can plan the appropriate stimulation. Whenever we are suspecting a polyp or a fibroid polyp, there is something in the endometrial cavity, it is best to examine in the follicular phase or just after the menstrual phase is over, wherein the endometrium is thin and it is easy to delineate a fibroid polyp or an endometrial polyp. For uterine anomalies, we need the contrast between the echogenic endometrium and the hypoechoic myometrium to be maximum. So whenever we are suspecting uterine anomalies, it is best to plan it in the second half of the cycle for getting the maximum contrast. So how do we prepare the patient for the scan? So it is always best to start with a transabdominal examination because we have seen that the transabdominal scan gives us a wide angle view of the bird's eye view of the pelvic organs. So sometimes there may be a large cyst or a large fibroid which might be if you directly do a transvaginal scan. And also always screen the kidneys and the bladder at least before doing the transvaginal or even going and looking at the uterus and the adnexus. So explain the transvaginal procedure before starting the scan puts the patient at ease and gives us maximum compliance. So if the lady contracts her pelvic muscles, it will be very difficult to maneuver the probe. So it is always best to start the scan after counseling the patient adequately. And using gynae couch or a couch where you can lift the middle part of the pelvis so that you can maneuver your probe from in this area. Or using just a pillow underneath the patient's buttock will give us best views of the pelvic scan. This is what I've said. You need adequate space for maneuvering your probe, especially in the lower part. So you need the pelvis part to be lifted up. And always for transvaginal scan, use sterile probe covers and also disinfect the probe between the scans. So probe orientation, we need to orient ourselves by looking at this is the marker for probe orientation. You have just as in transabdominal, you have it on transvaginal scan also. Always it will be pointing above, or you can right and left as according to your preference you can change. So that marks the yellow dot on the screen marks marks the probe orientation for you. So when we start a transvaginal scan, we just start with the screening of the whole pelvis. So when you insert, the first view that we get will be the sagittal view, and then we just slide the probe to left and right to get to the both the adnexal regions, and then we can go into the anterior fornix. You can see here this is the anterior fornix and the posterior fornix. So you can just manipulate the probe to enter the anterior fornix or the posterior fornix to get the visualization. In the anterior fornix, we can visualize the rectovaginal region, the bladder and all. Sorry, the vesico-uterine pouch, and rectovaginal you can see in the posterior fornix. So again, after that, you turn the probe to the transverse position, and again you move the probe from top to bottom, from the fundus to the cervix and the vagina, and then from side to side, including the both the adnexae. And you need to be liberal in maneuvering your probe. You need to visualize as lateral as the lateral pelvic wall. So you can see the iliac vessels and the lateral pelvic wall. So in your survey, you need to go all the way to the both lateral ends, including the lateral pelvic wall. So what are the challenges in visualization, especially in the transvaginal scan, when there is an obese lady, very deep pelvis? That time you can face difficulties in getting the views. So you can increase the depth, reduce the frequency and lift the pelvis so that, and most of them will have the shadowing from the bubble also. So the bubble moves away a little bit, and even if it doesn't work, you can just use bimanual compression, compress from the abdomen and then get the views that you want. Or you can plan your scan in the morning time where you can expect the bubble shadows to be less. Or if you're suspecting a DIA and you're not getting the proper views, you can even ask them for a bowel prep, just giving the electrolytes also in it. And especially when the uterus is in mid position like this, you're not able to see the nice midline echo, the endometrial echo. So it becomes very difficult to get the views and assess the endometrium. So in those cases also bimanual manipulation from pressing from the abdomen to get the sagittal view that we want. That will help in, now you can see that the endometrial echo has come into play. So we can do that. So coming to imaging of the uterus, this is the mid-sagittal view, that is the view that we start with. So you have to look at the continuity from the cervix to up till the fundus, and look at the nice serosal contour and the myometrium, the endometrial echo. Here it is a nice triple line, and the junctional zone is also very clear. So in this view, we can come across some fibroid, some mass that is disrupting the cavity here. This is jutting into this fibroid into the endometrial cavity. Or you can have a fan-shaped shadowing. This is an adenomyosis, and there is no clear delineation like the uterus that we saw in the previous slide. So this is an adenomyosis. Or you can, in a previous section, you can come across a bed-shaped defect in the region of the previous scar. So that's seen. These are some examples. And coming to various positions of the uterus, this is the usual, very easy to scan, that is the anti-vertic anti-flex position. And sometimes when there is endometriosis or radiations, you can have a fixed retroflex, retroflex uterus also. And this is a question mark shaped uterus, specifically in endometriosis and adenomyosis, we can see this one. So here there is anti-flex, but anti-flex means the relationship of the corpus with respect to the cervix. So this is anti-flex, but here again it is turning backwards. So this is the retroflex. So this is anti-virgin and retroflexed. And this is the mid-post uterus that we have. So while
for every pelvis scan, it is mandatory to take the LMP and find out on which day of cycle she is, because the same scan cannot be the same in each part of the cycle. It can be different. So always correlate with the timing of the cycle and whether the cycles are regular. So that gives the maximum benefit in interpreting the reports. So you can see the various cyclical changes of the endometrium. And in the endometrium, sometimes you can see a mass which is taking up color. There is a flow there. So this is an endometrial polyp. Then how to image the ovaries. Once you have finished looking at the uterus, then coming to the ovaries. So once you lose the fundus here, and then you just tilt your probe laterally, and then you can see the ovary just lying close to the iliac vessels. Sometimes it is difficult to image these ovaries in their usual position, especially when there has been a previous surgery. So, and if there is excessive bowel gas shadows. Again, we follow the same methods that I've mentioned before. Lifting the pelvis and then bimanual compression would help. Manipulation would help. Then after the ovaries, start looking at the adnexa. So you just follow the transverse view of the uterus, and then you can, this part is the adnexal region. Usually normal fallopian tubes we do not visualize on the normal scan unless there is a free fluid in the pelvis or if there is a pathology in the tube. So whenever there is a hydrosalpinx, you can see a mass here, tortuous mass with incomplete septations. That is a 3D rendered view. That's a hydrosalpinx. So that we can find on that view. Oh, this got missed. So using color Doppler, again color Doppler, it's better to use in every case, especially when we are assessing the endometrium, or especially when we are assessing infertility patients. So to look at the perifollicular flow, subendometrial flow, the polyp we have seen, and sometimes it can help in locating an ectopic pregnancy. So this example is a case where color Doppler is helpful. She is a post-abortal continuous bleeding PV. This is a 2D image. We can't delineate anything from this. So you can see that the endometrial echo is not very clear. There seem to be some retained products here. And when you switch on color, you can see that there is myometrial hypervascularity. This is a still image, the video. So that is an entity where it can cause post-abortal myometrial hypervascularity can cause irregular bleeding PV following a miscarriage. Coming to 3D, it is especially helpful when you're suspecting a uterine anomaly to localize the fibroid, where it is, whether it is indenting the cavity, and also in evaluation of the fibroid polyp, the endometrial polyps. Also, when you're planning an IVF cycle, you can look at the endometrium, measure the volume of the endometrium, and various uterine anomalies you can diagnose. And this is a fibroid here, that is an submucous fibroid jutting into the cavity, and there is another one just sitting on the endometrial cavity. So you can use a FIGO classification to find out say where it is in relation with the endometrial cavity. Also for measuring the follicular sono AVC to measure the follicles. This is in early pregnancy also sometimes you can you make use of the 3D. This is an angular pregnancy. You can see there, that's one cornuvalent and this is the other cornuvalent. So it helps in localizing an ectopic pregnancy whenever you have a doubt. So there are additional interventional tools you can use along with the transvaginal. You have the saline infusion sonography. Sonovaginography is especially helpful in looking at the rectovaginal area in the suspected endometriosis. Hysterosalpingography you can use for tubal patency using a 3D contrast. And always look beyond the uterus and the ovaries, because most of the deep endometriosis are getting missed, especially when there is subfertility and when the patient complains of significant dysmenorrhea. And dynamic ultrasound also helps, because sometimes they will give us say that there is pain while scanning, there is probe tenderness. All these help in evaluating, getting the best out of your transvaginal scan. So beyond the uterus and ovaries, we have to look at the, we have seen that the anteriorly the vesico-uterine pouch and then the rectovaginal area. Look at the bowel wall, the sliding sign of all the organs, and the lateral pelvic walls. Look at the ureters. Again, here comes the trans-abdominal examination, where we have seen in the beginning of our scan, where we can find, if you have a uterine anomaly, there can be associated renal anomalies. And if there is an endometriotic lesion compressing the ureters, you can have hydronephrosis in the kidneys. So the best way to start your scan will be with a good trans-abdominal approach. And this is just putting everything together. So usually before we used to like say first fill the bladder, look at the trans-abdominal, then empty bladder, come back for transvaginal. So instead of all that, now I just start the scan with an empty bladder. It is okay because we are just looking at as a screening. So we can always go back. So we start the scan with an empty bladder and then do a trans-abdominal sweep, trans-vaginal sweep of all the organs, and then look at everything in detail. And then by the time you finish the scan, there will be little amount of bladder filling. So again, whenever there is a doubt, especially sometimes ovaries are placed high above and you will not get them on the transvaginal. So by the time you finish your transvaginal scan, there will be little bit of bladder, and that window you can use for again localizing and evaluating the ovaries from the trans-abdominal approach. Thank you.